Hello and welcome to our Knowledge Brief Release webinar today titled COVID-19 Refugee Health Care Workers in Forced Displacement Settings, Challenges and Opportunities. This event is co-hosted with Physicians for Human Rights and the Columbia University Mailman School of Public Health, Department of Population and Family Health in the program on forced migration and health. This knowledge brief was produced by a research consortium led by Columbia University, American University of Beirut, University of Los Andes, Georgetown, and Brandeis Universities. This work is part of the program Building the Evidence on Protracted Forced Displacement, a multi-stakeholder partnership. The program is funded by the UK, aid from the United Kingdom Department for International Development, DFID. It is managed by the World Bank Group and was established by a partnership with United Nations High Commissioner for Refugees, UNHCR. The scope of this program is to expand the global knowledge on forced displacement by funding quality research and dissemination results for the use of practitioners and policymakers. This work does not necessarily reflect the views of the universities, DFID, World Bank Group, or UNHCR. COVID-19 poses a major threat to populations affected by forced migration and forced displacement due to overcrowding, inadequate water and sanitation, high existing morbidity levels, inadequate resources, and limited availability of healthcare workers. Safeguarding the healthcare workforce across all fronts of the response, formal, community-based, and informal health and social workers are essential to prevent health system collapse. Integrated refugee healthcare workers into the COVID-19 response can rapidly address health workforce gaps and strengthen the pandemic response. Proactive steps needed to be taken wherever possible to anticipate and mitigate the hidden burdens borne by healthcare workers, especially the impact of stigma and the strain on mental health, not to mention violence against healthcare workers. I'd like to introduce our panelists who will be addressing different aspects of these issues. Dr. Mesfin Tessema, Senior Director of the IRC Health Unit, Dr. Ranit Mishori, Senior Medical Advisor, Physicians for Human Rights, and a professor at Georgetown University School of Medicine, and Dr. Ihlas Altinci, Syrian family physician. Before the panelists give their talk and we open it up for Q&A, so kindly put your questions in the chat, we'll have a brief overview for this knowledge brief by Dr. Noor Adi, DRPH student in the Helbrun Department of Population and Family Health, Columbia University, Mailman School of Public Health, and Catherine McCain, Senior Program Officer, also Helbrun Department of Population and Family Health and the Columbia University Mailman School of Public Health. So without further ado, I'm going to turn it over to Dr. Adi.
Thanks, Rachel. The rapid spread of the COVID-19 pandemic challenged social stability and put health systems under enormous pressure to maintain functionality in the face of an exponential increase in population health needs. Healthcare workers are situated at the core of health systems building blocks. COVID-19 and previous epidemics, such as 2014 Ebola epidemic in West Africa and 2009 H1N1 pandemic, showed that healthcare workers' safety, functionality, and overall well-being are key determinant factors for health system performance and social stability in time of epidemics and other emergencies. Throughout the pandemic, healthcare workers faced a myriad of challenges affecting their health and capacity to respond to the pandemic. Unsafe working conditions, including long shift hours, overcrowded wards, and unstable supply of personal protective equipment, led among many other factors to high infection and death rate among frontline healthcare workers who are in direct contact with COVID-19 patients. Mental stressors, including isolation from family members, stigma, discrimination, financial insecurity, and in some cases, physical violence against individuals and health facilities, further exacerbated the impact of COVID-19 on healthcare workers and health systems. Those risk factors are not equally distributed. Healthcare workers in low-income countries faced further challenges, increasing their risk to COVID-19 morbidity and mortality compared with their colleagues in high-resource settings. Healthcare workers in fragile and humanitarian contexts faced even additional and unique challenges related to social and economic instability, systematic attacks against healthcare, and other forms of politicization and weaponization of healthcare and humanitarian aid. The most vulnerable in this hierarchy of inequalities and risk factors are the refugee and displaced health workers themselves, who were forcibly uprooted from their communities and are trying to reestablish their practice in their country of asylum. Challenges around accreditation and acknowledgement of their professional credentials are one of many unique challenges this group faces in particular. In this knowledge brief, we reviewed cases where refugee healthcare workers had significant public health and medical roles in countries' effort to respond to the COVID-19 pandemic. I move the mic to Catherine with a note that perhaps we could think of national health systems and non-governmental organizations' ability to recognize, reach, and recruit healthcare workers as an ideal measure of our ability to protect all the health workforce. Those who can center the most marginalized will be by design able to support the less marginalized groups. Thank you.
Thank you, Noor. It's a pleasure to be with you all here today. And I'll keep my remarks short so that we can hear from our wonderful panelists in just a moment. As Noor described, displaced healthcare workers are a vital and largely untapped resource in the global efforts to control COVID-19. In the United States alone, the Migration Policy Institute estimated that there were over 270,000 refugee and immigrant health professionals prior to the pandemic who were unemployed or significantly underemployed. But states, localities, and healthcare facilities must take care when mobilizing this workforce to ensure the appropriate precautions are in place. In order to give a sense of how countries are approaching this, I'm going to provide a short overview of some of the methods we identified in the brief that various countries employed, particularly in the first 6 months of the pandemic, and then our wonderful panelists will be going into more detail regarding these methods and ongoing approaches. Early in the pandemic, task sharing was widely relied upon in order to increase health worker capacity. For example, refugee outreach workers in Lebanon and Iraq provided COVID-19 prevention information and psychological support through camp-based wellness meetings, respectively. In addition, in countries such as Argentina and Chile, they began authorizing health professionals whose qualifications had not yet been validated by national authorities to join the workforce. Other countries such as Mexico and Germany began expediting the process for foreign credentialed health care workers to receive accreditation. Networks of foreign health professionals were formed by UNHCR and community-based initiatives in order to try to match health staff with local hospital and clinic needs. In the EU specifically, refugees can apply for the European Qualifications Passport for Refugees, or EQPR, which was developed in 2017. And while it does not provide a full qualification, it can serve as a step towards recognition. Some refugees were able to use this during the pandemic to work in the healthcare sector. But one of the limitations that we've seen both in Europe and elsewhere is that refugee healthcare workers were brought in as contact tracers, nursing aides, and supervised positions that did not necessarily take full advantage of the role and range of responsibilities for which they had trained. In the US, integration of refugee and immigrant healthcare workers into the health system was dependent on state, as each state hosts their own accreditation system. 8 states chose to temporarily suspend or adjust licensing requirements to specifically allow foreign trained healthcare workers to join the workforce. However, these programs were not without challenges, and the operationalization of this integration, both in the US and globally, is an ongoing challenge. In the brief, we discussed potential barriers and facilitators to integrating displaced healthcare workers into the workforce, and these fall into 3 main categories: policy barriers such as accreditation and other legal and financial hurdles, professional development barriers such as language skills and networking challenges, and finally, social barriers such as stigma. Throughout the brief, we outline methods for protecting the workforce across all fronts of the response, and we dive into the importance of integrating refugee and displaced healthcare workers into the health system in order to rapidly address health workforce gaps and strengthen the pandemic response. Finally, we discuss the proactive steps needed to anticipate and mitigate the hidden burdens borne by healthcare workers, especially displaced healthcare workers. We're excited to welcome you to today's webinar and look forward to hearing from our panelists on their insights and expertise on these important topics. Thank you.
Thank you, Noor and Catherine, for that introduction. So I'm going to start. We're going to have a conversation here. And I'd like to start with you, Mesfin, on thinking about your role at IRC and wondering what are the impacts of COVID on health service delivery for forced and displaced populations, using example from the work you've done in so many countries.
Thank you, Rachel. Thank you. Hi, everyone. Thanks for having me today to share our IRC's experience. I'm going to use few slides, so I will share my screen. Just a minute. Okay, so. Okay, so I think that goes very well with the screen. So, okay, sorry. Okay, so for those of you who might not be familiar about the IRC, I want to just give you a brief background. I mean, the International Rescue Committee is a humanitarian organization working in more than 40 countries and to help people who are affected by conflict and disaster to survive, recover, and gain control of their life. And the health program, which the unit I lead, is one of the 5 sectoral focus area for us as we are responding to crisis. And the health program, in a sense that we are working in more than 32 countries. And this includes, as you see on the map, in Asia, Middle East, and North Africa, in the African continent in general, and also Latin America. So 2020, last year, just a brief snapshot, that we supported more than 2,923 health facilities across these 32 countries, really primary health care to provide essential service for refugees and displaced population. And more than 13,000 healthcare workers we supported, and as well as 17,000 plus community health workers. So these are the health workforce that we work with. And through the, by working in the settings, our health program reached to more than 31 million people with access to primary health care. And as you can see on the slide, the breakdown of service that has been provided. So with that, the pandemic has not affected all countries or communities equally or at the same time. And infection among refugees and displaced population usually follows the infection trend of the host country. And as such, there is a spike and, flare up and, times of surge that we have observed in many of the places where we work. At the same time, among the population who are affected by conflict, I think infection among healthcare workers were quite high, especially during the early days of the pandemic. And in some countries, on average, 10% of healthcare workers have been infected. And in some countries like Sierra Leone, it's as high as 16%. So the major challenge healthcare workers in these settings have been facing is really inadequate access to personal protective equipment or weak infection prevention and control measures, and which are the major risks for increased healthcare workers infection. Currently, many countries are experiencing what we call a third wave, which is overwhelming health system in some of these places where we are working. In Sierra Leone and Liberia, we have seen almost 3,000-fold increase in cases in the past few weeks, and with high case fatality rate in places like Uganda. So this put a strain on the health system with shortage of oxygen and other supplies. So for IRC, where we work in this context, the foundation of our response consists of mostly a risk mitigation approach in order to ensure staff safety and the safe continuity of essential services. For people who are affected by conflict, access to primary health care is as life-saving as access to COVID treatment and prevention. So it really, as we are preventing and also responding to COVID, we want to make sure that this population also continue to have access to essential service. So that's why we adopted a risk mitigation approach for continuity of service. And across IRC country program adaptation were made to ensure those services are available throughout the pandemic, despite the restriction in terms of movement restriction we witnessed, logistics challenge in terms of moving supplies, and at the same time, our staff being sick with COVID, including healthcare workers who are providing care to the people. So we actually last year, we took major initiative to improve primarily the infection prevention control capacity across the more than 2,900 health facilities that we supported. It's no way this is a little task, but as we started off the process, of course, we assessed our clinics and hospitals in terms of the status of the IPC at the time in the middle of 2020 to understand the improvement that we need to continue. And as you can see on the slide, the result is quite surprising. Low IPC standard in many of the facilities we are supporting, although this is not different from what we see in many health facilities in low-income countries. I believe the WHO has done similar assessment and found out that actually around 15% of health facilities are the ones that meet at least 75% of the IPC standard. So on aggregate, among the assessed facilities, nearly 31% of the facilities surveyed had scored at least 65%, but this is nowhere closer to what we want. So based on our experience from Ebola outbreak responding in West Africa and DRC, we developed a minimum package of infection prevention control standard for COVID-19, which is primarily aimed at reducing transmission, but at the same time protecting our healthcare workers to ensure that they will continue to provide the essential life-saving services that are necessary for our clients. And the results of those assessments has actually helped us to address those bottlenecks in the IPC standard. As you can see on this slide, actually most of the challenges around triage and screening of patients as they arrive into health facilities. In general, the management structure in the health system, how patient flow and supplies and staff workload have been managed, and also really challenge around sanitation and access to clean water. And because of the investment we made earlier on in the pandemic, actually there was good IPC status observed around the cleaning and PPE or personal protective equipment. So these are the kind of intervention that is needed to protect healthcare workers in a pandemic and as well as disease outbreak. I think the kind of approach that we have taken actually mitigated the impact of COVID, and in many places actually we've been able to reduce the infection rate among healthcare workers. And we also collected monthly utilization data from our country program on a number of indicators over 12 months to understand actually if we have been able to maintain essential service. So we compared the period between March 2019 to February 2020, which is prior to the early stage of the pandemic, and the 12 months preceding the onset of the pandemic from March 2020 to February 21 of the pandemic. So analysis of this data found out that at a global level, the COVID impact on continuity of essential service has been minimal. In fact, number of clients who receive, for example, new contraception, outpatient consultation, consultation for mental health has actually increased, probably a reflection of the adaptation, and at the same time, a reflection of the increased need for mental health service in this kind of context. But we have also seen a decrease in service utilization, especially those that require inpatient care, like deliveries attended by skilled personnel has reduced, and also a number of children who receive immunization. So overall, we believe that the healthcare workers, especially frontline healthcare workers, are the critical for ensuring sustainability of essential services. We must do everything possible to protect them and keeping them safe so that they will continue to provide service that is necessary for people affected by conflict. I will stop here. I'm happy to answer any question that's coming through the chat box. Over to you, Rachel.
Thank you so much, Mesfin. That was really illustrative of some of the challenges and the fact that certain services are affected more than others, but really, really important. So I'm going to turn it over now to Ranit to United States into the health workforce. And I know you might touch on some examples from other countries like Germany, UK, and others, into sort of routine health care delivery to address some of those shortages that come up in pandemics. Over to you.
Thank you very much, Rachel. I'm going to share my screen with all of you. So 1 second. All right. So I want to start this talk, and every time I talk about it, I am reminded of my grandmother. This is from her wedding day, and she was a refugee and a healthcare professional. And I always remember her talking about having to scrub floors and dust blinds in homes and offices because that was the only employment she could get after her migration. And it was only after several years after her migration that she was able to reestablish herself in her prior career as a dentist. So this was, I think, about 80 years ago now, but the obstacles that she faced, and I'm always reminded of that, are very similar and haven't really changed for other healthcare professional turned refugees, and they're not unique to her or to that place and time. And as many of you know, I think to date, many doctors and nurses primarily and dentists fleeing dangerous conditions in their home countries end up finding themselves either underemployed or unemployed. And we see doctors driving cabs and nurses washing dishes and PhDs running cash registers at grocery stores. And you know, it's a tragedy because their skills are unused and their potential contributions to society are completely untapped. So many of them, like my grandmother, find themselves working in low-skilled jobs and getting to training programs that force them to reestablish their careers, often at a great price, personal and financial. I think Catherine already mentioned this work by the Migration Policy Institute of all of these immigrants who are health professionals who have some medical training, but really are unable to work in their field because of credentialing and licensing rules. And of course, we call this brain waste, and it's a significant problem. You can see the number of people, this skill underutilization. A quick comment about the data, and oftentimes, my colleagues and I try to ascertain how many of these are actually forced migrants, refugees, and asylees, but it's really, really difficult to split the data, break up the data, and it's one of the weaknesses that we address in some of our work is that the need to really know who these individuals are and not just kind of lump them together as immigrant health workers. Rachel mentioned that there are interventions across the world, and this is true during COVID. So the issue, of course, of this brain waste came front and center during the pandemic, and so many countries were facing an urgent need for healthcare workers because some doctors were falling ill, and same with nurses. They had to quarantine themselves, and there are severe workforce shortages at the time. So in response, the US and other countries, and these are two examples from Germany and the UK, but this is also true of Spain, France, Ireland, and others, where foreign trained doctors responded to the call to join the local healthcare systems and received some form of fast tracking so that they could work, but many actually ended up working only in medical support roles, as I think Catherine already mentioned. And of course, there was a huge support at the UNHCR level from the commissioner, who was specifically very supportive and praised these efforts and called for at the time for more countries to implement these emergency measures. And this is a quote from one of his speeches. But of course, as we now know, this really wasn't enough to address both the country need, but also the potential contributions of the forced migrant health workers. And this is one such example of an Iraqi physician who was working in LA he was helping take COVID tests. So he wasn't really working to his full capacities, but several states in the United States, Colorado, New York, and New Jersey, have signed orders at the time that allowed foreign trained and licensed refugee health professionals to aid in the COVID-related activities. But really, this was primarily for support personnel. I want to highlight the fact that this is not unique to the United States. And of course, refugees have had a long and very successful history of making economic and cultural contributions. And this is from an Australian campaign that featured and highlighted the contributions that refugees have made to their host country. And on the left, you can see a physician. But the integration has, as Catherine already mentioned, has been very tough, regardless of which country or which setting you look at. And this is, again, another campaign from the UK, where we see that integration worked to some extent, but it seems that integration into the healthcare system has been particularly tough. And that was a shame, because many of these countries, including the US, have areas with documented physician shortages, or regions and cities and states with a high proportion of immigrant and refugee populations that could really benefit from healthcare professionals who share language and culture and could potentially connect better. But of course, one of the issues, and I'm going back to the United States here, is the healthcare professionals who want to practice in the context of the US, whether they're nurses or physicians, and it may be a little bit tougher for physicians, they must undergo time and labor and financially a very, very intensive process. It includes eligibility confirmation, which of course is more difficult if you are an asylum seeker or refugee, and if you come from a war-torn country and you've lost all of your papers. They must pass multiple tests and exams. Some are called the USMLE exams. They're incredibly expensive. Then they have to apply for and complete residency programs afresh. Even if they've worked as doctors in their home countries for decades, they have to retrain. And this could be pretty stressful, but also, there are issues related to dignity of having to do that. And then they have to apply for licensure. And this is all done sort of in the guise of and in the name of quality. But if we look at the research about, and again, this is lumping, sorry, my dog. This is lumping them into the immigrant or foreign educated doctors, and not doesn't specify whether they're forced migrants or not. But there are studies that they're at least, in terms of the quality, at least as good as any US trained physician, if not better. And this is a study from a few years ago that shows the mortality rates among Medicare patients who have been treated by foreign educated doctors is actually lower than by US trained doctors. So the integration requires many stakeholders to work together. It requires concerted efforts from state and federal health authorities, medical associations, private entities, and nonprofit organizations, and higher education institutions. And my colleagues and I have written about this. And there's more information in those articles if you're interested. But most of these programs are really very small in scale and seem very disjointed. and almost as disjointed as our healthcare system itself. And these are some recommendations from one of our articles, and I'm happy to send anyone others. But the key is that it needs to be coordinated, and the voice and the experience of forced migrant health workers themselves needs to be considered. It's not something that the host country can do without tapping into the expertise and of the population that is being helped itself. So I'm going to end with this UNHCR, and this is, if you look at this link, it's a really nice article specific to COVID-19 related to the health workers who were in the United States and were really doing their best to try to help. And really, COVID has given us this great opportunity to re-examine how our healthcare system in the United States operates and what needs to happen for it to function a little bit more efficiently and equitably. And so as we reimagine and re-examine our broken healthcare system, and all of these gaps have been shown with stark colors during COVID, we need to think about how to harness the knowledge and the skills of forced migrant health workers. And I hope that this brief that we're talking about today is going to be a really good start in the process. So I'm going to stop right here, and we'll be happy to take any questions a little bit later. Thank you.
Thank you, Ranit. That was excellent. And I think you brought up so many important points about not utilizing the workforce we have both in the US and abroad, given some real barriers to sort of becoming a part of the medical system. I'm not going to go into specifics, but I know Noor personally has had family that has experienced exactly what you're talking about, where you're a specialist, not just on the residency, but a specialist in another country. You have to go back and repeat the residency and the specialization, which could take up to 6 years. If you do a 4-year residency, a 2 or 3 year fellowship, it's daunting. And yeah, so I really appreciate your data-driven argument. So with that, I'm going to turn it over to Dr. Altinci. I know you have a deep experience working in Syria, and I want to know, what are some of the challenges faced by health staff working in Northwest Syria, and also pivoting a little bit to displaced Syrian populations in Turkey who have medical degrees, nursing degrees, midwifery degrees. How have they faced those challenges that are exacerbated by the health worker shortages? I know this was actually an issue that came up given the large numbers of forced migrants to Turkey, both before the pandemic as well as after the pandemic. And I think Turkey is a great example of looking to some thoughtful solutions. So I'll turn it over to you. Thank you.
Thank you. Thank you very much for my colleagues. So basically, I'll be speaking specifically about the Syrian context. And as you might know, the crisis has been going since more than 10 years now, with all the complications that it holds. Speaking about the health staff and how they were impacted, by the crisis, the main risk, let's say, that they are facing on a constant basis is shelling and targeting of health facilities. So this didn't stop for the last 10 years, unfortunately. And it was one of the main reasons why many health staff had to immigrate, had to leave Syria and find other safe places where to practice their medicine or nursery or midwifery, indifferent of their initial education and position. And of course, this, in addition to the crisis itself, the destruction of the infrastructure and all the other complications happening in the Syrian context, no governance body and so on, put a huge burden over the health sector, all of it, and specifically over health staff. I mean, if we look at the Syrian context, we see that it is run by the, if I can say so, the non-governmental organizations, the UN agencies. There's no a real health governance body that can control the sector, lead it, guide it, and manage it. So a bit of the work is chaotic in some cases, if I can say so. But of course, I mean, the WHO, the health cluster, the other clusters, we have many clusters and sub-working groups who are trying their best to coordinate the work among the different actors working in the health sector and guide it. Speaking about, the challenges faced by the health staff working in Turkey, I mean, let's say the challenge number one was the language and a bit the different cultural aspects of Turkey in comparison to Syria. I mean, me and my family came to Turkey in 2013, and I wasn't able to do, and go through all the long and expensive process of validating my diploma as a doctor. I couldn't afford that because I had to work in order to feed my family. I cannot sit for 1 or 6 months, I don't know, or 1 year, dedicate it only for study in order to get my diploma validated. I applied my papers, by the way, to the higher education ministry. They said, yes, you are a doctor, we know this, go and do the exam. And I never did it because I cannot afford it, I can't afford the time dedicated for this exam. And there are many, I mean, colleagues who did the same. So, or they work illegally, they open clinics, they practice, but if the government or the authorities find about it, then they are arrested, they might go to jail if there's, a specific case of, I don't know, fatality or something goes wrong, or they immigrated to other countries. And as we saw by these slides showed by Dr. Ranit, the huge number of Syrian doctors waiting in Germany for the validation of their diplomas and so on. Unfortunately, adding to all those, serious issues, complications, we had the pandemic. I mean, the first case of COVID-19 was registered almost a year now. And fortunately, I can say the numbers are not that high of death. It's only about 700 in northwest Syria. I'm talking about northern Aleppo and Idlib governorate. And it's the areas controlled by the opposition forces, whereas in the government-controlled areas, the death registered, it's not, I mean, the official numbers, and of course, we know how it might vary from the reality. It's about 2,000. The recovery rate was very high, I mean, thankfully, but again, the health staff were hit hard. I mean, if we look at the first case that was registered, which was a health staff working between the borders between Turkey and Syria. And actually, he was the first person to be tested and confirmed as a case of COVID-19 in northwest Syria. And of course, this caused a huge burden on health staff, caused stigma. Health staff were afraid to report, I mean, if they have symptoms, they fear to lose their, workplaces. And because of the gap that is existing in health staff generally, and specifically in specialized doctors and so on, there were some pressure that don't give them off days, don't give them, the period they need to sit at home and take care of themselves, because they have to work in multiple places. One doctor cannot afford working in only one place. It cannot be in the Syrian context. One doctor should work at least in 4 to 5 facilities in order, to cover the needs, the huge needs that exist in the in the region there. So again, if we talk about, the resources, the personal protection equipment, the medication, the equipment needed to treat patients, and so on. And we saw cases of, stable governments, stable countries with huge resources and couldn't, meet the needs. So you can imagine how it was at the beginning in the Syrian context. It was really difficult for health staff and for the coordination bodies, to cover those needs. But thankfully, efforts were put in place, triage tents were put in front of each health facility, referral networks were put again in place. So health staff would know where to refer a patient, how to manage a case, how to trace contacts, how to identify a case, Of course, this was in conjunction with huge efforts for sterilization, building, if I can say, or establishing sound wash facilities for health staff and for the patients to be used. Distribution of masks and many other efforts in order to lessen the effects of this pandemic over the population there. But again, we had many meetings with some beneficiaries, some patients, and health staff, and unfortunately, they always used to tell us that we have all the troubles and hurdles in the world. We have, distracted countries, so a tiny virus would be the least that we can think of. We cannot sit at home. We cannot afford work from home. We have nothing to do from home. Actually, if we don't go out and work, we would die of hunger. So it's a bit different for the Syrian context. And I'll stop here. Thank you very much for listening.
Thank you so much. There's some questions coming in to the Q&A on the chat. So I'm going to encourage all panelists to look at questions. Some are specific to individuals and some are more general. So I'll give you a chance to look at the chat. Dr. Altinci, that was excellent. And I think you gave us some real granularity in terms of the challenges faced by Syrian healthcare workers. And I'm going to move a bit back to a question that was asked to Mesfin in terms of challenges that health workers face during the pandemic. What has IRC done specifically to support these health systems and healthcare workers? And a corollary to that is, how are you able to navigate the challenges of these healthcare worker shortages, while also ensuring that as a large NGO, you're not drawing away from Ministry of Health public sector workforce so that the system maintains its robustness and that there aren't sort of two parallel systems at play? And so we'll start with that question and then we'll move into the chat, other chat questions.
Yeah, thanks, Rachel. Happy also to answer the question in the chat box related to the vaccine for humanitarian workers. So in terms of the challenge for the healthcare workers, I think as I outlined in my presentation, access to personal protective equipment was a major barrier at the earlier on. And I think we have made quite significant investments to improve, PPE availability of PPE in both health facility we manage directly or the health facility we support. Most of them are run by partners as well as Ministry of Health. And I think the other challenge is, in many of our contexts, there has been a challenge in terms of access to testing capacity for COVID. And that had limited in terms of understanding the extent of the spread and also, who is at risk and who is for isolation, even just contact tracing. So, earlier on, it took 2-3 weeks to get test results back, which is probably rendered useless. So we actually, the introduction of the rapid antigen test has really made difference in terms of on-site testing. I think we are doing that. And in many of the facilities, actually, especially those who are running along, for a long time, like the camps that we support in Kakuma and Dadaab in Kenya, we have a gene expert machine, which we have been using for TB diagnosis. And with updating the cartridge, and we'll be able to do actually PCR on site in the refugee camp. So, of course, the cartridge is, again, the limitation. So those are, the work that we have done. And I think we also need to understand that, the challenge around, COVID itself, and now with vaccination, misinformation, disinformation, really understanding, even among healthcare workers. So really providing them the right information quite earlier on, even from the start of the pandemic, what is it and what's not. And really just before a rumor set foot in that space, really providing them the right information. Those are the point that we focus. And now with the availability of vaccine in many places, we are working and advocating for inclusion of refugees, displaced population, as well as the people working in those settings. And as the COVAX, which is the facility dedicated for this purpose, rely on national plan to support. And we do look at the national plan if it include refugees, displaced population, and healthcare workers in terms of criteria. We are not asking special privilege. It's rather actually fair and equitable access to everyone, irrespective of a refugee status. Unfortunately, many national plans don't include refugees in their national deployment plan. I think we have worked to advocate on that. I think the humanitarian buffer, which has been established to mitigate that, has its own challenge in terms of operationalizing it, but it is a safety net that we have. And I think without having adequate resource for deployment and delivery of this vaccine, even that mechanism may not deliver. So I think we have a lot of work to do to make sure that actually people are not left out. I think lastly, mental health for healthcare workers. I do think this is underappreciated, and it's a major challenge personally for the healthcare workers and for their own family, and quite a lot of burnout, restriction movement. Our healthcare workers, if they have to leave Dadaab camp to take a week off in Nairobi, the quarantine requirement to go and to return, and the testing regime is quite exhausting by itself. So I think we do need to support, providing a mental health support group and helping them to cope with some of those challenges, what we have been working on. Just on the question on vaccine for humanitarian workers, again, it's just part of the national plan that we have, make sure that they are included. But I think, for humanitarian workers, the UN is also making available those vaccines, and we want to make sure that our staff also benefit from that. So, earlier on, the UN system was not really including every humanitarian worker. I think with time, I think that eligibility criteria has been expanded. So those are some of the work that we've been doing, to support our healthcare workers in the place where we are working. Thanks.
Sorry.
Maybe I may have missed the last question. If I may respond quickly.
I was going to ask.
Yeah, on the the healthcare workers, especially those who are working in public health, and I think it's good to recognize that our primary objective and also our preferred is that for refugees to be integrated in the national health system, and we know that most refugees live outside camps, and supporting the Ministry of Health, whether with with incentive for the healthcare workers or with capacity development, and a range of things that could be done to help Ministry of Health to respond to the surge need. And I think that is our primary focus. But we do also train additional healthcare workers, whether that is frontline workers like community health workers, primary healthcare workers. We have partnerships with universities, to do continuous learning for some of them. So we don't want to deplete the existing health system, rather strengthening it. But where there is gap, we do hire staff even bringing them from other part of the country where there is, a health workforce available to be deployed. But again, I think, as it is outlined in the brief, even among refugees, there are healthcare workers, and identifying them, helping them to be recognized in the national system, and integrating them is what probably deliver better results. And in some countries like Thailand, for example, healthcare workers from Myanmar are not recognized or at least licensed to practice in Thailand. So, but in our refugee camp, actually, those are the healthcare workers who are providing care. And so with negotiation with Ministry of Health, we have been able to let them actually continue practicing and providing support with the supervision of the Thai healthcare workers. So those are the kind of approach that we are pursuing. Thanks.
Okay, super, thank you. There are more questions in the chat. I'm going to move on to Ranit just so we can hear from each person. But I think Mesfin, there's a question regarding the sort of different, the decrease in ambulatory service utilization with the pandemic, the rate of COVID cases, especially in Venezuelan migrants compared to the host population. So I'll let you think about that. And then I know maybe you don't have specific vaccination coverage rates for healthcare workers with IRC, but I think you alluded to it, given that the COVAX facility has had operational challenges, especially with the humanitarian buffer. And we know there has been supply issues, obviously, with the large pandemic affecting production in India to all countries, including the humanitarian buffer. So I know you sort of alluded to that, but maybe when I come back to you, if there are specific coverage rates, as well as some of the other comments in the chat. I'm going to move now, if that's okay, to Ranit. And there's sort of two questions. One is, what has been tried so far in the US to facilitate healthcare worker integration from refugees or from foreign medical practitioners to make sure that we're utilizing all of the very high skills that they come with in terms of really overcoming those challenges that you elucidated in the in your talk regarding USLMLE, having to repeat residency, fellowship. So I'm going to start with that and then move back to some of the other questions. And I think there is sort of a corollary question in the chat looking at, are there specific guidelines developed for integration of personnel, minimum standards that are universal, or are they all specific to countries? So I'll let you touch on that one if you have time. That's from Rajiv C.
Thank you. Before I respond to your question, very briefly, and Dr. Altinci's remarks made me think about that, is that it's also important to recognize that I think that the figure is about 70% of the health workers globally is women. And as she mentioned, if you're a woman and you're the healthcare worker and you have your children that you have to raise, and you're not able to find help in getting reintegrated, and then there's COVID on top of that. I mean, it's a triple whammy against you, and it's really very, very difficult. And I think we need to also see this from a gendered perspective, and then in that equity lens. But very briefly, to go to your question, I think it depends very much on where you are. If you're in the United States and you happen to live in Minnesota and you're a healthcare worker, you lucked out, because Minnesota is one of the few states in the United States that actually has had more concerted programs for refugee and immigrant health workers to be integrated. And partly is they figured that it would be a way to address healthcare shortages in rural areas and in the primary care workforce. So, unfortunately, that's few and far between, and not a lot of states don't have state-based programs like that. And in the US, as many of you may know, it's pretty much on a state-by-state basis. We're not aware of any federal programs that help refugee or immigrant healthcare workers be reintegrated. I wanted to highlight two programs that are a little bit better than the others. They're programs at the state level, they're programs at academic institutions, and then they're sort of national and regional programs that are private or nonprofit. And one is called Upwardly Global, and it has very specific programs for healthcare workers and physicians. And it starts from orientation to the U.S. healthcare system, to core training, tips, doing interview practices, and teaching strategies to prepare for residency interviews, for USMLE testing, helps with apprenticeships and observerships. It's very hard in the United States to get to be, if you don't know the healthcare system, to get an internship or an observership, so you can get a letter of recommendation from somebody in the hospital or in a healthcare setting. And so all of these, there's one-on-one coaching, there's networking, there's even financial support. So this program, Upward Global, is one of the few that actually has been launched in a few states, in California, Illinois, Maryland, and New York, and with some success, and there's some data collection about outcomes. And the other one is called Welcome Back Initiative, which is in about 9 states, and it's very similar. It's not limited to physicians, but it does offer sort of comprehensive and integrated coordinated services on a one-on-one that is completely free to the health worker. So these are two of several, but the two that are the largest. As far as standards, again, in the US, there aren't any standards. I think it's every country has its own medical standards, which is why it's so difficult to be a practicing physician in one country and then try to move to another, because the testing, the quality, even the culture of healthcare are so vastly different that it's very, very difficult to get integrated. And of course, on top of that, there's discrimination and racism and the perceptions of what country you come from, and whether the health education system there is, up to snuff in your own country. So there's a lot of issues of sometimes false perceptions about where you came from and the level of education that you received. And I've worked at a community hospital in Washington, D.C., where the majority of people were from other countries. And I have to tell you that when it comes to making diagnoses and not relying on technology to manage, to reach diagnoses and manage patients, those skills were far, far better than many of my American colleagues who rely on CTs and MRIs and labs, and have a hard time identifying the presentation of illness. So I know that personally I benefited so much as a trainee in working with clinicians from other countries. And I'll stop right here.
Thank you. That was really helpful, because I know it is state by state. It's confusing. It would be very helpful to have standards that are obviously that are more lenient and more flexible than most of the states. So maybe we can look to Minnesota. So I want to turn it over to Dr. Altinci. Do you have any final comments? I know we only have 3 minutes, maybe 2. I know you wanted to talk a little bit about some of the issues regarding women and girls and your experience with reproductive health. But if there are other questions in the chat you want to respond to, also please feel free. But I want to give you the final word.
Thank you very much. So basically, I'll speak very quickly about the sexual and reproductive health services we provide as CARE International in Northwest Syria. And as Dr. Ranit said, gender is at the center of our work. Integration between sexual and reproductive health and gender-based violence services, again, is the aim of our work. Child marriage, early marriage, forced marriage are in very high rates now in the Northwest and in all of Syria context. We're talking about a rate of 30 to 40% of all marriages are early or forced or child marriages. So basically through our work, we try our best, to provide some knowledge and services to specifically adolescents. And we have a program called the Amal Initiative, which is Adolescent Mothers Against All Odds. that we currently work in, and it targets the adolescents, the entourage of the adolescent, the society, and the healthcare providers. I would speak very quickly as a final comment about, female health staff. And I thank, again, Dr. Ranit for mentioning this. At the beginning of the pandemic, we heard voices that personal protection equipment should be delivered or distributed only to male health workers, and specifically doctors, because they are rare, precious, and very hard to be replaced. Whereas midwives, nurses, they can be replaced more easy. And that was, very difficult for me to hear. And of course, we didn't allow this to happen. PPEs were distributed to everyone equally as they were available, hopefully. And that's it, in addition, to all the hurdles faced by health staff, we need to specifically mention what difficulties female health staff can face. Thank you. I'll stop here because of the time.
Yes, I think, Dr. Tessema, you want to quickly respond to the Columbia question, and then we'll wrap up.
Yeah, thanks. Just to the question I think, Donald, regarding the outpatient consultation, the figure I gave is a global, and as I said, the pandemic play out in different countries differently. And even in our program, we saw a dip in service utilization in March, April, May, earlier on in 2020. And then it went back up to where it was in 2019. And then even some services actually increased utilization. So it's very hard to say, one trend holds true everywhere, but I think, yes, in some places decrease, in some places increase. And also, I think some services that doesn't necessarily require face-to-face contact has really maintained throughout the pandemic through, less frequent contact, but, patient follow-up for chronic disease like that. So that's just one thing. And certainly infection among refugees and displaced population in many contexts has been low. And I think partly because of, reduced contact with the general population. And I think the Rohingyas probably be a good example that, the Bangladeshi government, letting them stay in Cox's Bazar, don't allow them to go out, actually has limitation in terms of access to opportunities and job, but it has prevented them from getting infection. So it's, there is benefit and risk. And I think these are some of the things that we have seen playing out. Thank you.
Thank you for that. And I'll leave that as the closing remark. And I think just to highlight what sort of some of the data-driven challenges that we're seeing, even in a recent report out of India, that we think the excess mortality is now 4 times what has been reported. And so we know those data are difficult to measure, especially in a pandemic with a contracted health workforce. So we'll stop there. I just want to thank our panelists for their valuable time. I want to thank Physicians for Human Rights and the Program on Forced Migration and Health for hosting this. And thank you for the participants to spend your hour in the morning or wherever you are in the evening, an hour during your summer, and Mubarak to many of you. So thank you so much, and have a wonderful day.